Hello everyone, in this video we are going to discuss about anatomy of hand. So here the bones of the hand are shown in this picture. From proximal to distal we have carpal bones, metacarpal bones and phalanges. So firstly we will talk about the distal part, that is the phalanges. Each finger have 3 phalanges, that is proximal, middle and distal phalanx. So thumb has only 2 phalanx, that is only proximal and distal. This is the unique feature of the thumb. Clinical relevance is distal phalanx injuries are more common in crush injuries or fingertip trauma. Next is the metacarpals. So these includes which constitutes the palm. So from lateral to medial side we will name it. That is from the thumb side to the little finger side. That is 1, 2, 3, 4, 5. Thumb side is the 1 and the little finger side is the 5th one. The first metacarpal is short, mobile and important for thumb position. Clinical relevance is Boxer's fracture, which is a fracture of the 5th metacarpal bone, as you can see here, and which involves the 5th metacarpal neck. Bennett's fractures and Rolando fracture are the fractures of the first metacarpal, base of the first metacarpocarpal joint. This is the clinical relevance. Next, coming to the carpal bones or wrist bones. There are 8 bones arranged from the proximal to distal end. We will always name it from lateral to medial side, that is from the thumb side to the little finger side. So first one is scaphoid. This is scaphoid. This is lunate. This is triquetral. This is pisiform. This is this is trapezium. This is trapezoid. This is capitate and this is hamate. So when we see it, scaphoid is the most commonly fractured bone because of there is a risk of avascular necrosis. Lunate is most commonly dislocated bone and causes compression of the median nerve. Then pisiform is the sesamoid bone, which is formed within the flexor carpi ulnaris. Distal row and trapezium articulates with first metacarpal and trapezoid. Capitate is the largest carpal bone and hamate has a hook, which hook of hamate fractures cause ulnar nerve damage. So we can see that there is hook here at the hamate bone and capitate is the largest carpal bone. Next, coming to the distal end, these are the forearm bones at the wrist joint. They are radius and ulna. The clinical feature is distal radius fracture, that is Colles fracture, occurs due to fall on outstretched hand. This picture shows distal end of radius fracture here, which is causing dinner fork deformity. This is the dinner fork deformity. And ulna, it forms a stable base for the wrist and is less commonly fractured. So coming to the clinical relevance, so this is the hook of hamate where the ulnar nerve passes. So whenever there is an injury here, there is more prone to ulnar nerve compression. So scaphoid is the most common carpal bone. Any tenderness in the anatomical snuff box, there is high risk of avascular necrosis. So whenever patient complains of injury to the hand and there is tenderness in the anatomical snuff box, we should always suspect scaphoid fracture. Most commonly X-ray will be normal, so we should always do MRI to rule out it, because there is high chance of avascular necrosis because of the retrograde blood supply. Here what happens is from the radial artery, from distal to the proximal end, the blood supply will be there. So whenever there is injury here, the whole of the bone will be necrosed because of this retrograde blood flow, because of no absence of any collaterals here. So next is lunate. Lunate is most commonly dislocated carpal bone and it causes median nerve compression, which causes carpal tunnel like symptoms. Hook of hamate, as we see, ulnar nerve fracture, ulnar nerve damage, sensory loss in medial half and weak grip is seen. 5th metacarpal joint, Boxer's fracture. 5th metacarpal bone, Boxer's fracture. 1st metacarpal, Bennett's and Rolando. Distal phalanx, commonly seen in crush injuries. Radius, Colles fracture. Coming to the first metacarpal bone fractures, that is Bennett's and Rolando, we have to see Bennett's fracture is an intra-articular fracture where the fracture divides the bone into 2 segments, and it is an unstable fracture because of the pull from the flexor pollicis. And the Rolando fracture is a comminuted fracture. There is more stability here, but Bennett will have more good prognosis than Rolando because it is a comminuted fracture. And here we will do K-wiring. Here we have to since it is, we have to operate it more, Rolando fracture. So these are the important points of bones of the hand.